Well, thanks for joining us for another episode of our DCCares. And currently we're doing a series of these podcasts thinking about people who are caretakers for loved ones that are going through dementia or Alzheimer's. And we know what a difficult journey that is, and oftentimes just knowing what the resources are that are available. And one of those resources has to do with medication. And I have with me Becky Godby. And Becky, your husband is Louis Godby. He's the pastor at Olympic View Church. Right. But what is it that you do?
Okay, so I'm a psychiatric nurse practitioner. I work with psychiatric diagnosis and psychiatric medication management. I have an independent practice, Olympic Psychiatric Care, that's here in Sequim. And I have been owner and sole provider at that location for the past 7 years.
Okay. So tell me about being a psychiatric nurse. What does that mean? How is that different from a regular registered nurse?
Yeah, so I have advanced training in psychiatric care, and so a master's degree with postmaster's training in this specialty area. And it allows me to diagnose and prescribe, and usually I follow up with patients on a routine basis to make sure medications are working well, that they're getting the results they desire, that type of thing.
So for a person who is going through some form of dementia, Alzheimer's or something, what can medication do?
Yeah, well, it's variable. Medication cannot cure Alzheimer's disease. It can slow the progression. And the two primary medications that I prescribe, donepezil, years ago you would have seen this advertised on TV while it was still a brand name drug called Aricept. And the other one that I prescribe is the brand name was Namenda, the generic name is memantine. And donepezil is for mild to moderate all the way to severe dementia, and memantine is usually used for moderate to severe dementia. And these medications can have side effects, so you have to be careful with using these medications to be sure they're not causing more harm than good. And as I said, they don't cure the problem, they can just slow the progression. So you probably have an understanding that Alzheimer's is the primary cause of dementia in people over age 65, and it's a slow progressive disease, and this use of this medication might be able to keep a patient in their home a bit longer. I always like people to know the limits of care and medication, because honestly, with this slow progression, there comes a time when medication is not going to save the day. This person progresses to a point, particularly when they're no longer sleeping at night or they get combative, that you are probably going to have to use more than these types of medications and more than just care in the home to have everybody's best life. Whenever I have a patient with cognitive decline, particularly Alzheimer's, I let people know there's two patients, the caregiver and the patient themselves, because there's a reason there's 3 shifts at a nursing home. One person cannot possibly do all the care that's needed, and it's knowing when that line is that's critical in this slow progressive disease. It's like that infamous frog in the boiling water. Sometimes
Right.
You don't realize how hot, how difficult, how much it's taking out of you. And that's one of the things that I do as a care provider, is help them understand when they need to make some of the very hard decisions in this progression.
If someone is using one of these medications, you said there's side effects, there are downsides to these medications. What does the upside look like in the day-to-day experience? Does it help to quiet agitation? Does it help with sleeping? Any of that?
Not typically, and that's the problem. When you have a slow progressing disease and it's just slowing the progression, it's kind of, yes, this can help, but you're not going to see a lot of change. So you remember, this person is forgetting how to do things, and it might keep them able to ambulate longer, able to feed themselves longer, but you're not going to see like, oh, they were like this and now they're much better. It's just slowing that progression, theoretically. And so if a person's on a lot of medications or has trouble swallowing medications, or you don't want them to take medication, there may be a questionable reason even to start these medications. But some of the side effects to watch for are nausea and GI symptoms like diarrhea, or like if a person has a poor appetite, you might not even want to start these medications because it could decrease their appetite, and you would not want that. So that's one of the things, if I start medication, I'm really watching for tolerability, but I'm not going to see something that's like, aha, they're so much better. That's just not what you see with these.
Now, one of the things that I hear people talk about, you talk about the toll it takes on the caretaker. And for sure, part of that is when that loved one is becoming very agitated, or like you say, the sleep problems. Mm-hmm. Is there anything medically that can be done to help that person with the sleep or with the agitation if the person doesn't feel they're ready yet to go into more significant full-time care?
Yeah. All the medications that are typically prescribed for agitation come at a cost, and that cost is it can mess up ambulation, and it can kind of be a vicious cycle, that if you give a medication that causes somebody to be more sedentary, they can, be more agitated because they're not burning off that energy. And these are medications, if you're using an antipsychotic medication, like, for instance, people know Seroquel. They've heard of that, also known, the generic of that is quetiapine. That medication can help make people more sleepy, less agitated, but it's got a black box warning that it can increase strokes, death, falls. And so it's kind of a last resort, and I really hate to go to those medications. One of the best things that I encourage people to do if a person is becoming agitated is distraction. Music, calm environment, not shouting at them, not yelling at them, not pulling on them, but just remaining calm and distract them from whatever they're doing that's problematic. And as this disease progresses, sometimes they get very belligerent with self-care. And, if it's not life and death, I encourage them just to table that and address it later, much like you would work with a small child, and just try to get through the day with as few conflicts as possible. But the medications for agitation, most of them are, a double-edged sword for sure. And so I use them very judiciously, cautiously, smallest effective dose, and with lots of warnings that if this, is causing problems, they're no longer getting up, may have to do something different besides that. Okay. So antipsychotics, lots of dangers with them. Sometimes we use some mild sleep medications. Two of my favorites to use, mirtazapine is a very low-risk medication that can help people with sleep and anxiety, and that can just be a golden one to use. Another one, trazodone, that can help people fall asleep and stay asleep. Another low-risk medication that can help with sleep. So those are two that I use with a pretty clear conscience and very low risk for those two. They can typically take those from now until forever and not have big problems or worries.
Okay.
Yeah.
What do you say to that caregiver who is, as you said, there's this other patient that any guidelines you have for them, just thinking about themselves, to know if they're reaching that point where they need to bring in other help or put their loved one into care?
Yes, I have a lot to say about that, and I say a lot about that. And the big piece with that is sleep. Sleep is our cornerstone of both mental and physical health. And if people's sleep is being interrupted, remember, this is not like a little child, because little children you can keep contained. A person with Alzheimer's disease may be wandering. They may go out the door. They may turn on the stove. There can be so many things that even if you're trying to rest, that you have that ear open for that person. What's going on? Are they getting out of bed? And so on and so forth. And if you're not able to get 7 to 8 hours of sleep, then you can expect your reserves to go down, that you're going to get progressively more irritable, more frustrated, and elder abuse can be a huge problem. I mean, this person that you love and want to care for, you just become so frustrated and irritated with them that your relationship with them goes downhill. And I encourage people to pay attention to that. And one of the things they can do if they want to keep that person in their home is bring in help. They need the caregiver needs a chance to get outside the home, go grocery shopping or go for a walk or do something without worrying what's going to happen. Is that person going to, fall or get out of the house and go somewhere? You need that mental break. And so I encourage people to bring in care or even care overnight. So somebody's sitting right there, because those falls that happen in the middle of the night can be total game changers, and there's a lot of guilt and frustration that happens because, gosh, I couldn't watch over them 24/7, and nobody can. And so people have got to either bring in help when that downhill slide, when they're not sleeping well, or you can't leave them alone without worrying what's going to happen with a fall or wandering, leaving the house, or doing something that might threaten your existence. And then sometimes it's just the right time to do placement. And what I encourage people to do, if it's reached that point, they're not sleeping well or that person has become aggressive toward them, and many times family members are the ones who get the aggression because they're the ones that are interacting, or maybe there was conflict in the past and now it's really ramped up. And so I encourage them to visit the care facilities. We have several here in this town, and just talk to other people who have family members there, and you can learn a lot. And sometimes it's just the most beautiful thing. They go into that facility, and rather than saying, oh, this is going to be the end of everything good, the person actually loves it. They have people like them to sit and talk with, and they enjoy their meals more. And when you come in to visit them, it's a happy day. You both have a nice visit, and then you get to go home and you get a good night's sleep. So I tell people there's not, you don't have to wait till things are terrible to make this decision. You can find that it's just like the best thing for everybody. So I encourage, look around and keep an open mind, and be kind to yourself. That caregiver needs a lot of blessing in their life for what they're doing.
Yeah.
And to not feel guilty that they need time away.
Yeah, that's good. Well, and just so you know, part of this podcast series, we're going to have some people come in and talk to us about respite care options and our memory care centers. So
yeah, that is a fabulous thing. There are opportunities, for adults to be watched over while you go to the store for 2 hours, or like I say, bringing people in. But that's just an absolute must. Yeah.
Good. If someone is wanting to explore more about medications that may be helpful, do they just start with their primary care provider? Would they call an office like yours directly? What's the next step?
Yeah, many of primary care providers are familiar with these medications and good at prescribing them. If they are not comfortable with that, they may recommend somebody else. The number one thing is to make sure you know what you're dealing with. And once this has been concretely established that we have this disease process going on, then things are pretty clear for the most part what to do next. So if the diagnosis is established, everybody knows you've had enough time to watch this cognitive decline going, yes. And if your primary care provider isn't comfortable with that, they have their people that they refer, because remember, this is no longer uncommon. This is well known, and it's a pretty clear treatment path for most providers. They get it, is what I want to say, I guess.
Good.
Yeah.
Well, Becky, thank you so much for taking some time, and we hope that this has been helpful for you. Again, one of the reasons we're doing this is we want to give you resources to care well for your loved ones if you're going through this journey, but we want to care well for you as well, because we know that for the caregiver, this is a difficult road to walk. And so any ways that we can pray for you, that we can encourage you, and some practical tools we can give you to help you along, I just hope that's a blessing and encouragement. So, Becky, thank you so much.
Yes, you're most welcome. It's a pleasure.
Okay.
Okay, all the best.